Welcome to my channel. In this video, we will discuss what is Hodgkin lymphoma. So Hodgkin lymphoma is a malignant condition in which there is proliferation of the lymphocytes inside the lymph nodes. So it has a hallmark, that is there is presence of Reed-Sternberg cells. These are special type of the lymphocytes that contain two nuclei in which there are prominent nucleoli. These are Reed-Sternberg cells. There are several types of Hodgkin lymphoma. First one is nodular lymphocyte predominant Hodgkin lymphoma. It is slow growing and mostly it is localized and it is rarely fatal. Other type is nodular sclerosing. Nodular sclerosing is, as the name indicates, that it contains roses. It contains roses. So it is more common in females and it has good prognosis. Roses, good prognosis. Then we have mixed cellularity Hodgkin lymphoma, that is mainly in the adults. Then lymphocyte rich, which has good prognosis. It is rich, so it has good prognosis. Then lymphocyte depleted, which is depleted, it is poor, so it has poor prognosis. It is similar to anaplastic NHL. Clinical features. The clinical features of Hodgkin lymphoma are: there is painless lymphadenopathy. This lymphadenopathy is mostly seen in cervical region as well as the supraclavicular region, mostly in the cervical region. There may be hepatosplenomegaly, but hepatosplenomegaly can occur due to other diseases. Furthermore, there is porta hepatis, where the lymph nodes enlarge and lead to obstructive picture. Lymph nodes enlarge and lead to obstruction at the porta hepatis. So you can see obstructive picture. Then there is, as I have told you, the lymphadenopathy is painless, rubbery, and these lymph nodes involved in the contiguous spread, and then another node and then another node in a contiguous manner. We will do staging here. So if lymph nodes are present on one side of the diaphragm, diaphragm and involve only one lymph node region, then it is stage 1. If more than one region is involved, more than one lymph node region is involved, but on the one side of the diaphragm, then it is stage 2. If more than two lymph node regions are involved and are on the both sides of the diaphragm, then it is stage 3. And if extranodal lymphatic tissues are involved, for example spleen, liver, bone marrow, extra lymphatic tissues are involved, then it is stage 4 and it is diffuse involvement, stage 4. Now we will discuss the laboratory findings in Hodgkin lymphoma. Mostly we will do CBC. CBC may show may be normal or may show normochromic normocytic anemia or may show lymphopenia, and if these abnormalities are present, then it is a poor prognostic sign. Then we should do all baselines, especially LFTs. If they show hepatic infiltration, then these are durant, and sometimes there is obstructive picture due to obstruction of the lymph nodes at obstruction of the bile duct at the porta hepatis by lymph nodes, as I have told you. Then LDH, if it is raised, then it has adverse prognosis. If chest X-ray is done, then it may show mediastinal masses, especially in case of nodular sclerosing. Then we do CT. CT scan is done for chest, abdomen and pelvis to do the staging of the Hodgkin lymphoma. And then we do lymph node biopsy. Lymph node biopsy is to confirm which type of lymphoma it is. So it shows Reed-Sternberg cells, two nuclei with prominent nucleoli. Then what is the treatment of Hodgkin lymphoma? Hodgkin lymphoma is treated with a combination of chemotherapy and radiotherapy. For chemotherapy, the regimen is ABVD, that is doxorubicin, bleomycin, vincristine, and dacarbazine. Dacarbazine. So these four drugs are mostly used for the treatment of Hodgkin lymphoma along with radiotherapy, and mostly 4 to 5 cycles are done. For severe this Hodgkin lymphoma that is not responsive to this therapy, we do BCOP, that is bleomycin, etoposide, adriamycin, C stands for cyclophosphamide, and O stands for oncovin, P stands for prednisone, and next P stands for procarbazine. Other options that are present in the unresponsive patients are hematopoietic stem cell transplantation.